India spends around 3 to 4% of its GDP on healthcare, which is compared to the Western world spends around 9 to 10%, and US spends 17 to 18%. So that means we are a poor spender on healthcare, and every penny we spend, it is the responsibility of the medical professional to make it cost effective. And talking about that, this is what the everyday case scenario is for any physician or a doctor. A perimenopausal lady with low bone mass, elderly walk-in routine patient, elderly patient presenting with fragility fracture with no prior treatment, elderly patient with fragility fracture on treatment. How many of you are confident of treating all these 4 different scenarios? Before I prepared this lecture, I was not. And if I thought I was mistaken. Now, let's have a conservative estimates of how bone health and osteoporosis lines up in India. The at-risk population, which is diagnosed as more than 50 years, is 30 crores in India. Hip fracture incidence per year is 6 lakhs. Significant spine fracture incidence is even more, it is around 10 lakh. As path delineated, they kill. They are not only morbid conditions, they are mortal conditions. 1 year mortality rate with hip fracture at a conservative estimate is 20%, so it makes it 1.2 lakh deaths because of osteoporotic hip fractures. 1 year mortality with spine fracture is at the rate of 10%. It makes it 1 lakh deaths in India itself because of osteoporotic spine fractures. Median hospital stay for any osteoporotic significant fracture, vertebral or hip fracture, is around 12 days minimum. Total number of hospital days spent by our elderly would be 1 crore 92 lakhs. Average hospital day cost is around 5,000 rupees per day, including bed, everything. So it would be 9,600 crores spent on osteoporotic fractures only. These are conservative estimates. Let me put it. I may be off by at least 50% here. Now, for those who are thinking, why are we talking about osteoporosis? It's not that important. I mean, unless somebody has a fracture, it's not important. But this is how it lines up with the serious diseases which we all like to treat. It is at par with all the serious medical diseases, which include stroke, pneumonia, heart attack, with the mortality rate which is comparable, which has a cost which is higher than any of these. Cost spent on osteoporotic hip and vertebral fractures is higher than any of the serious diseases which we would like to treat. And the number of days a patient spends in the hospital because of osteoporotic fractures is way higher than any of the serious diseases which the same patient is going to suffer in his or her lifetime. So it is important. Not only that, if you have a osteoporotic hip fracture and you happen to be treated even in the best care centers, the best you can expect is only 20% chance of complete recovery, even with the best of the treatment. 20 to 30% would not make it to the first anniversary of the fracture, and those who make it to the first anniversary of the fracture, 50% of them would not be what they were before the fracture. So it is a serious disease. And add to it the complications of the treatment itself. So the disease is bad itself. The results of perfect treatment are at best average. And if somebody happens to have a complication on top of it, you can imagine the scenario for that patient. You can have implant cutouts, you can have infections, you can have n number of complications which can be not only morbid but mortal. So for any condition, we have been told ever since we were MBBS students, prevention is better than cure. And there is no condition like a bone health which can be prevented. And the prevention starts from the day the child is born. Why is it so? Because the bone in our body is like a bank. We have a bone bank. Now, whatever we may do, it's the natural law that our deposit in the bone bank will increase till 35 years of age. And whatever we do, the bank balance would decrease after that. So if we do certain things before 35 years of age, we will reach a peak bone mass, which would be good enough that even if it decreases, we would not reach the risk level. So everything done at the age before 35 is good enough. So bone health is something in which if you intervene at very level, at any level, you will make a difference. So you need to know it. And for that, you need to know the bone structure. Now, what we think is that bone health is directly related to vitamin D, calcium, but that's not true. That is as far from the truth as it can be. Bone is like a pillar. So you have a metal matrix, which is the protein fibers, the collagen fibers. It's like a saria of the building. The calcium and phosphate is the cement of the building. The vitamin D is the worker who's making that building. And the exercise is the willingness to build that building. So until or unless you have a proper protein intake, you have a proper calcium intake, you have a proper vitamin D intake, and you have proper stimulus, and that is weight-bearing exercises, as Path also delineated, you cannot have a good solid bone density. All four are equally important, and all four of them have to be taken in unison. So calcium has to be good, vitamin D has to be good, protein intake, oft neglected in India in vegetarian diet, has to be good. I'll just give you an example. 0.8 to 1 gram per kg body weight. That's the minimum requirement of protein per day. And exercises, 20 to 30 minutes of any sort of weight training is good enough. It need not be bodybuilding, it's just a weight training. That body is being loaded. As simple as walking or gardening is good enough. Now, regarding the existing treatments, they are highly efficacious. They reduce the risk of osteoporotic fractures by 30 to 50%. That they are that efficacious. And they are cheap and they are safe. But the question is, are they beneficial as compared to the other modalities? Yes. With the use of anti-osteoporotic drugs, you can decrease the risk of your patient of dying by 20 to 40%. You can decrease the risk of new fracture by 20 to 40%, and you can decrease the cost by 20 to 40%. That is the amount of benefit these drugs have on bone health and treatment of osteoporosis. If we like to compare it with the other diseases which we want to treat, you can see the mortality reduction per dollar spent is highest with anti-osteoporotic drug. So they are considered to be the most cost-effective therapy medical profession knows, which is even better than the anti-diabetics, anti-hypertensives, and the drugs to prevent stroke and everything. So these are those effective. Compared to the cost effectiveness, again, oral bisphosphonates are amongst the best to treat any disease, any condition across medical fraternity. So when we are talking of osteoporosis, we have a disease which is amenable to treatment. The treatment is cost effective and it prevents deaths, it prevents morbidity, and it saves cost. But next question, then why are we not doing it? Is it not safe? This is the safety profile. Of all the medications in medical fraternity, probably anti-osteoporotic drugs are the safest amongst all. Now, everything is falling in place. Next, then we must not be having the right diagnostic modalities. That's why we are not treating it. Diagnostic modality, it is right there on your cell phone. You tap on online and you do a FRAC score. And a FRAC score would give you immediate guidelines of what to treat. Even if you do not have a DEXA scan in your vicinity, or the patient cannot afford it, or if you cannot, or you do not want to get it done, just a FRAC score is enough for you to guide treatment for osteoporosis. Now, we have a disease which has high incidence, has a high morbidity and mortality, has a high cost of treating complications, can be easily diagnosed early, has effective treatment which is both cheap and safe, but this is how we are performing. 80% of the people who should be having treatment are not having treatment. And this is first time. Even when the fracture, even when the patient presents to a clinician with a fracture, out of those patients also, 80% do not receive treatment. We are failing as clinicians. Why is that so? I can only think of these reasons. We do not appreciate the seriousness, or we do not know the right way to evaluate, or we do not know the right way to treat, and because of those three things, we tell that our patients are not compliant. But if we cater to the first three things, and we ourselves are convinced that these patients need treatment, most of the patients would follow the treatment just the way they do for diabetes, just the way they do for stroke, just the way they do for coronary artery disease. So let's begin to change. First, how to evaluate and whom to evaluate. Anybody more than 50 years of age should be evaluated with a FRAX score. If you just go out of this hall after this lecture and do a FRAX score for yourself, it would take less than a minute. Now, next question, how do you interpret it? That's the next question. FRAX Plus is an app which is paid, so obviously we have reluctance to use it. I can appreciate it. It is around 7,000 rupees per year, but doesn't matter. The NOC guidelines give you this table, so you just have to dial in what the FRAX score is, and you have to dial in the age, and you have to see on this chart. You will get green, yellow, light red, dark red. And what does that mean? It basically gives you a 10-year probability of a major osteoporotic fracture, and you see where your patient is falling, and based on that, you can be in the green half where you just give the lifestyle advice. In the middle half, you treat them yourself. A physician, a simple plain MBBS doctor can treat it, and if they fall in the top bracket, very high risk group, then you consider referring to a specialist who has interest in bone metabolic disorders. So very, very, very easy to follow and very objective with clinical guidelines, international clinical guidelines backing the entire concept. Now how to treat? We know all, calcium has to be taken, vitamin D has to be taken, protein, blah, blah, blah. But what we need to know is there are osteoporotic drugs, and they are of two classes: anabolic, which build the bone, and anti-resorptive, which decrease the resorption of the bone. And there is a science to what you should prescribe in what patient. And since osteoporosis is a lifelong disease, you need to know the sequential therapy, because no one class of drug can be given end on for life. So the maximum a class of drug can be given is 10 years, and that to only select patients. So these are the drugs. So anabolic drugs are teriparatide, abaloparatide. Abaloparatide is not available, and rososumab. These are the anabolic drugs, and anti-resorptive drugs are bisphosphonates, which can be oral and IV, as well as the denosumab, the wonder drug, so-called wonder drug. But you need to know sequential therapy. Why? Because any anti-osteoporotic drug has a specific duration for which it can be given safely. For bisphosphonates oral, the duration for which it can be given is 5 years, maximum 10 years. For an IV bisphosphonates, it is 3 years minimum and maximum 6 years. For denosumab, it is 5 to 10 years. For teriparatide, it is 18 months to 24 months. For rosumumab, it is 1 year. Hormone replacement therapy, again, that is a domain which endocrinologists should look at, seeking the risk-reward ratio. So a patient who has been diagnosed with osteoporosis at around 50, if the average life expectancy is around 80, for 30 years, you would have to think of a sequential therapy, where you start with one drug and then you move on to other drugs so that you can have a disease-free, event-free life. And what is that sequential therapy? This table guides you what is the sequential therapy. So certain drugs would have a reversal of benefit immediately, like denosumab. You give denosumab and you withdraw and do not give anything else. The baseline risk actually increases. So patient who has been on denosumab, if the drug is withdrawn and nothing else is given, there would be a reverse significant osteoporosis with multiple fractures. So, and similarly, this table gives you what works after what. So typically, any anti-resorptive therapy has to be substituted with an anti-resorptive therapy. So if the patient has been on bisphosphonate, you follow it up with a denosumab, which is anti-resorptive. Any patient who is at a high risk, you start with building the bone. So you give anabolic drug like teriparatide and rozumumab, and then follow it with bisphosphonates. A good sequential therapy chart is like this. Bisphosphonates being easy to take and cheap, most of the patients qualify for taking bisphosphonates. After 12 to 16 weeks, you call the patient again and see whether they are compliant or not, and then every year you sequentially evaluate them. There was a question by Dr. Vitul who asked that, can the osteoporosis be reversed? It has been shown that if the treatment is started at the right time and is diligently followed, it can be reversed, and you regularly follow. If the patient is compliant and the risk is low, then you can think of giving a drug holiday. If it is not, then you sequentially shift the patient after the complete dose to the next class of drug. So this is a table for the oral bisphosphonates, which tells us how to follow the patient and how to sequentially get to the different class of drugs. So now if we have an everyday case scenario, perimenopausal lady with low bone mass, any takers, what would be done? It's a common phenomenon. Perimenopausal lady comes to you with a backache, and you do a FRAC score or a BMD, and it has a low bone mass. It's not osteoporosis, it's low bone mass. So what should be done? The answer is you start the patient on oral bisphosphonates. And if the patient is low risk for breast cancer, then hormone replacement therapy also can be considered till the time the complete menopause has not set in, right? Now, elderly walk-in routine patient with multiple joint pains, multiple backache, would you screen for osteoporosis from now on? Any elder? Yes. So if you screen and the patient is a high risk for fracture or is classified as a treatment group, what would be the choice? So again, the drug of choice would be bisphosphonates oral, and if he is a very high risk, then IV bisphosphonates. Elderly patient presenting with a fragility fracture. The fracture has happened and you're treating the fracture and you're doing the BMD also and the FRAC score, and the BMD shows very high risk. So what is the treatment then? So you start with anabolic first, teriparatide, give it for 2 years, then shift to bisphosphonates. After 10 years, shift to denosumab. That is how you will take the patient to 20-25 years. Elderly patient with fragility fracture on treatment. The patient had treatment, it can happen. Despite treatment, it is not 100% guarantee that the patient would not fracture. So if the patient is on osteoporotic treatment, has a fragility fracture. Now the treatment would depend on what treatment the patient was. If it is teriparatide, you continue with teriparatide, and then after teriparatide, obviously you shift to bisphosphonates and denosumab. But if the patient was on denosumab, don't make the mistake of shifting the patient to teriparatide. If at all teriparatide has to be taken, it is an add-on therapy. It is not a substitute for denosumab. Otherwise, there would be a reflex increased bone loss. So these are the certain things which have to be kept in mind. And there is a one guideline, NOGG, NOG guideline, and ACE guidelines, which every physician should read, whoever is looking after a geriatric patient, to make real difference in the bone health of an elderly patient. Don't panic if there is a fracture. What all of us should know, one basic point is that mobility is life. In an elderly hip fracture, there would be comorbidities, and guidelines are in place which tell us that comorbidities are not to be treated before the fracture is fixed. Rather, fracture should be fixed along with the comorbidities for better rehabilitation and better clinical outcome. And the time from fall to first walk should be less than 48 hours. That should be the aim. And most of the patients, if they are treated in a specialized center, would be able to achieve this. And the reason is this last picture. We owe it to our elders to treat them well. Thank you so much.